If you took a pill before bed last night to help with pain, or to sleep, or to manage your blood pressure and you are over the age of 60, there is a very real possibility that while you were sleeping, that pill was quietly working against your heart. Not dramatically, not in a way you would feel immediately, silently, the way a slow leak in a pipe works for months before the ceiling gives way. I have been in clinical practice for more than 2 decades, and I want to tell you something that most routine medical appointments simply do not have time to explain. The 3 categories of pills we are going to discuss today are among the most commonly taken medications by adults over 60 in the United States and the United Kingdom. They are sold openly, in pharmacies and grocery stores, without a prescription. Many of them carry brand names you have trusted for decades. Several of them are sitting in your medicine cabinet right now. And according to the 2026 updates to the American Geriatric Society Beers criteria, the most authoritative medical reference document in the world for identifying medications that are potentially inappropriate for older adults, all 3 of these categories are now more explicitly flagged than ever before as carrying serious, specific cardiovascular and neurological risks for adults over 60. This is not about medications being universally dangerous. It is about timing, about biology, and about the specific ways that the aging body processes these compounds differently at night than it did when you were 40. Stay with me through all 3, because the third one, the one that almost no one talks about, is also the one that the 2026 FDA safety data identifies as the most commonly misused medication in the entire senior population. Before we get into the list, I want to share what the research says about the overall scope of what we are discussing. A 2026 report from the CDC and the American Geriatric Society found that adverse drug events are responsible for more than 177,000 emergency room visits by adults over 65. Every single year in the United States, 177,000, and a significant portion of those events occur in the nighttime and early morning hours, the hours when these 3 categories of medications are most commonly taken and when the aging cardiovascular system is most vulnerable. Let us begin. Number 3. NSAIDs taken at night for pain relief. NSAID stands for non-steroidal anti-inflammatory drug. This is the category that includes ibuprofen sold as Advil and Motrin, naproxen sold as Aleve, and dozens of other common pain relievers that adults reach for routinely to manage arthritis, back pain, joint discomfort, and general aches. If you are over 60, have been managing chronic pain, and you take one of these before bed to help you sleep more comfortably, please listen carefully to what happens inside your body during those hours. Here is the biology, and I want to explain it in a way that makes this stick. Imagine your kidneys as a water treatment facility that runs continuously. During the day, when your body is active and your blood pressure is naturally elevated by movement and wakefulness, that facility operates with good flow. Water moves efficiently, waste is processed, everything functions as designed. At night, your body enters a state of deliberately reduced activity. Your blood pressure naturally dips during sleep by 8 to 14% in healthy adults. Your heart rate slows. Your metabolic demands decrease. This is not a malfunction. It is a precisely engineered biological process called the nocturnal dip, and it is one of the most important things your cardiovascular system does every night to protect itself. NSAIDs interfere directly with this process through a specific mechanism. They inhibit the production of prostaglandins, compounds that help regulate blood flow through the kidneys and help maintain the kidney's ability to excrete sodium and fluid. When prostaglandin production is suppressed by an NSAID during the night, the kidneys retain more fluid than they should. That retained fluid raises blood volume. Raised blood volume raises blood pressure, and it raises it during the exact nocturnal hours when your cardiovascular system depends on that pressure dipping to recover. Research published in the British Medical Journal analyzing data from over 100,000 adults found that taking NSAIDs was associated with a significantly elevated risk of heart failure hospitalization. That risk was most pronounced in adults over 65 and in those with pre-existing hypertension, which, as of the 2026 American Heart Association data, now affects more than 70% of adults aged 65 to 74. A study specifically examining nighttime NSAID use and cardiovascular events found that nocturnal NSAID consumption produced significantly higher blood pressure readings during the nighttime monitoring window compared to daytime consumption of the same dose. The nighttime timing compounded the cardiovascular risk because it struck directly at the period when the heart needed low-pressure rest. The 2026 Beers criteria update is explicit. NSAIDs should be used with extreme caution in adults over 65, with particular attention to cardiovascular risk, kidney function, and gastrointestinal integrity. For nighttime use, meaning as a sleep comfort aid for chronic pain, the risk-benefit calculation is especially unfavorable. I saw this directly in my own clinical experience with Harold, 72 years old, from Manchester in the United Kingdom. Harold had been managing moderate osteoarthritis in both knees for about 8 years, and for 4 of those years he had been taking 2 ibuprofen tablets before bed to help him sleep through the discomfort. His GP had never specifically addressed the nighttime timing. His blood pressure had been gradually creeping upward over those 4 years from a well-controlled 122/76 to a consistently elevated 141/89. He had been prescribed an additional blood pressure medication to manage what his previous doctor had described as age-related hypertension. When we reviewed his full medication history and the timing of his NSAID use, the connection became clear. We transitioned Harold to a topical diclofenac gel applied to his knees at bedtime, delivering local anti-inflammatory effect without the systemic prostaglandin suppression. Within 8 weeks, his nighttime blood pressure readings had returned to the 126/78 range he had maintained a decade earlier. His additional blood pressure medication was tapered and eventually discontinued. The synergy tip for this category: if you are managing chronic pain and finding that nighttime discomfort is disrupting your sleep, discuss with your physician the use of topical NSAIDs, which deliver anti-inflammatory benefits directly to the painful joint while largely avoiding the systemic cardiovascular and kidney effects of oral NSAIDs. The evidence base for topical diclofenac, specifically in older adults, is strong, and the safety profile is dramatically more favorable. Number 2. OTC sleep aids containing diphenhydramine or doxylamine. Walk into any pharmacy in the United States or United Kingdom and look at the sleep aid section. You will see Tylenol PMs, Quil, Nitol, Unisom, dozens of branded products, all framed as safe, gentle, non-prescription sleep solutions. Many of them carry reassuring names. Several of them have been in your medicine cabinet so long they feel like old friends. Here is what those products contain that your doctor may not have specifically discussed with you. Diphenhydramine is a first-generation antihistamine, the same chemical found in Benadryl. It was developed in the 1940s. It works as a sleep aid because it crosses the blood-brain barrier and blocks histamine receptors in the brain, which creates sedation. At the time it was developed, the full range of its effects in aging adults was not understood. We understand it now. Doxylamine, found in Unisom and several nighttime cold formulas, is a chemically related compound with similar mechanisms and similar risks. Here is what the 2026 FDA safety data says about these compounds in adults over 60. First, the half-life, the time it takes for your body to clear half of the drug from your system, nearly doubles as we age. A younger adult might clear diphenhydramine in 6 to 8 hours. An adult over 70 may carry the drug's effects for 12 to 16 hours. This is why so many seniors taking these products report morning grogginess, impaired balance, and cognitive fog well into the following afternoon. They are not experiencing a hangover. They are still medicated. Second, and this is the finding that the 2026 update to the Beers criteria highlights most urgently, these compounds are potent anticholinergics. Anticholinergic drugs block the neurotransmitter acetylcholine, the chemical that carries signals between neurons in the brain and between the nervous system and organs, including the heart. In younger adults, the brain has sufficient acetylcholine reserve to tolerate this blocking effect without significant symptoms. In adults over 60, where acetylcholine production has already naturally declined, anticholinergic drugs produce what researchers call an anticholinergic burden, a measurable, cumulative neurological suppression that has been directly linked in multiple large studies to accelerated cognitive decline and increased dementia risk. A study published in JAMA Internal Medicine following more than 3,000 adults over age 65 for more than 7 years found that higher cumulative use of anticholinergic drugs, including diphenhydramine, was associated with a significantly increased risk of dementia. The researchers found that taking an anticholinergic drug daily for 3 or more years was associated with a 33% increased risk of developing dementia compared to those who took the medication for less than 3 months total. On the cardiovascular side, these compounds have a specific risk that most people are entirely unaware of: Anticholinergic drugs can cause reflex tachycardia, a rapid increase in heart rate that occurs because acetylcholine normally helps regulate cardiac rhythm when you suppress acetylcholine activity with diphenhydramine or doxylamine. The heart rate can accelerate unpredictably in an adult over 60 who already has coronary artery disease, atrial fibrillation, or uncontrolled hypertension, all of which affect over 75% of adults over 60. This nocturnal heart rate acceleration places significant additional stress on cardiac tissue that is already compromised. Beyond the cardiac and cognitive risks, these compounds cause urinary retention, especially in men with enlarged prostates, bladder instability, dry mouth, and blurred vision. Combined with the significant sedation that lingers into the following morning, they represent one of the leading pharmaceutical contributors to falls and fall-related fractures in the senior population. The 2026 emergency room data from the CDC documents that a substantial proportion of senior fall hospitalizations occur in the nighttime and early morning hours after taking sedating sleep aids. Barbara, 69 years old, from Birmingham in the UK, came to me with what she described as increasingly poor memory over a 2-year period. She was forgetting conversations, losing words mid-sentence, feeling, as she put it, like her mind was wrapped in cotton in the mornings. She had been assessed by her GP and told her cognitive changes were consistent with normal aging. When I took a complete medication history, I discovered she had been taking 2 Night-All tablets nightly for nearly 3 years. The drug's anticholinergic burden had been quietly suppressing her acetylcholine system night after night for over 1,000 nights. We worked with her physician to discontinue the sleep aid and replace it with a behavioral sleep protocol: consistent sleep and wake times, a cool bedroom, 10 minutes of diaphragmatic breathing before sleep, along with low-dose melatonin at 0.5 milligrams, which the 2026 clinical guidance identifies as the safest OTC option for adults over 60 who need sleep support. Within 6 weeks of stopping the diphenhydramine, Barbara told me the cotton had lifted from her thinking. Her word retrieval was sharper. Her mornings were clearer. She had not needed a prescription change. She needed to stop taking a medication she had trusted for 3 years. The synergy tip for this category: if you are currently using an OTC sleep aid containing diphenhydramine or doxylamine, speak with your physician about transitioning to low-dose melatonin between 0.5 and 1 milligram, taken 30 to 45 minutes before sleep. Unlike diphenhydramine, melatonin does not carry anticholinergic burden, does not suppress acetylcholine, does not cause cardiac rhythm disruption, and does not accumulate in the system with extended use. Its safety profile in older adults is substantially more favorable. Number 1. Certain blood pressure medications taken at the wrong time of night. I want to be precise about this one, because the nuance matters and I do not want anyone to stop taking their blood pressure medication based on anything said here. This is specifically about timing, not about stopping. Here is what the research and the 2026 clinical data have identified. Some physicians recommend taking blood pressure medications at bedtime to ensure coverage in the morning hours when blood pressure tends to rise sharply as the body transitions from sleep to wakefulness. There is genuine logic behind this. Early morning blood pressure surges are associated with increased cardiovascular event risk. The thinking is that a bedtime dose maintains drug levels through the night and covers that morning surge, but here is what that guidance does not fully account for. During normal, healthy sleep, blood pressure dips naturally by 8 to 14%. This dip is called the nocturnal dip, and it is biologically essential. It is during this low-pressure window that the heart muscle receives the greatest blood flow through the coronary arteries. It is during this window that the arterial walls experience the most complete rest. It is during this window that the body does a significant portion of its cardiovascular repair. When a blood pressure medication is taken at bedtime in a dose calibrated to control waking blood pressure, it can suppress blood pressure below that natural nocturnal dip in adults over 60, particularly those on alpha blockers, certain calcium channel blockers, or alpha-2 agonists. This can produce what is called nocturnal hypotension, blood pressure that drops too low during sleep. As one cardiologist writing in a 2026 clinical commentary put it directly, when you are asleep and your blood pressure medications push that pressure lower than your body's natural night dip, your brain and heart can experience reduced perfusion during the very hours when cellular repair depends on adequate blood flow. The practical consequence emerges not just during sleep but at the most vulnerable moment of the night for older adults. When you wake at 2 in the morning to use the bathroom, Your body's barorestors, the pressure sensors that detect your rising and trigger rapid adjustment to maintain blood pressure as you stand, should activate immediately. But if your blood pressure is already suppressed by a medication, those barorestors have less range to work with. The adjustment is sluggish. You stand up, perfusion to the brain drops momentarily, and you fall. The CDC data on fall-related hospitalizations in adults over 65 is stark. Falls are the leading cause of both fatal and non-fatal injuries in this age group, and nocturnal falls following bathroom visits, falls that occur in part because blood pressure medications have suppressed the compensatory response that keeps you steady. When you stand, account for a significant portion of those events. A study published in JAMA Cardiology examining evening versus morning blood pressure medication timing in older adults with hypertension found that while evening dosing did improve night to morning blood pressure coverage, it also significantly increased the incidence of nocturnal hypotension and orthostatic hypotension, the dizziness experienced when standing, compared to morning dosing. Thomas, 78 years old, from Edinburgh, Scotland, was referred to me after his third fall in 12 months. All 3 falls had occurred at night, when he rose to use the bathroom. His injuries had been minor bruises, a sprained wrist, but his family was frightened, and Thomas himself had begun sleeping in a recliner because he feared falling from his bed. His medication list included lisinopril, taken at bedtime as his previous physician had instructed. His nighttime blood pressure readings, taken during a 24-hour ambulatory monitoring session, showed readings in the 95/58 range during the 2:04 a.m. window, that is too low for a man of his age, and cardiovascular history. With his cardiologist's guidance, we shifted his lisinopril to a morning dose. His nighttime blood pressure stabilized in the 110/68 range, well within healthy nocturnal parameters. In the 8 months since that change, Thomas has had no falls. The synergy tip for this category: if you are currently taking a blood pressure medication at bedtime, do not stop or change the timing without speaking to your physician first. This is essential. But do ask your physician specifically whether morning timing might be more appropriate for your medication class and your cardiovascular profile. Ask about 24-hour ambulatory blood pressure monitoring if you are experiencing dizziness when standing at night, morning fatigue, or if you have had falls. That monitoring data will show your physician exactly what your blood pressure is doing during the critical nighttime hours. Now let me close with something I want you to carry with you. The 3 categories we have discussed today: nighttime NSAIDs, anticholinergic sleep aids, and blood pressure medications taken at suboptimal timing, represent some of the most common pharmaceutical contributors to cardiovascular stress, cognitive decline, and fall-related injury in adults over 60. They are not exotic medications. They are not unusual combinations. They are on the shelves of every pharmacy and in the medicine cabinets of millions of homes. The 2026 updates to the Beers criteria and the FDA's expanded safety flagging of these categories represent the medical establishment catching up with what clinical geriatricians have been observing for years. The aging body processes these compounds differently. The timing of when you take them matters in ways that packaging never explains, and that routine appointments rarely have time to address. This is not about fear. It is not about distrusting medication. Most people over 60 need some form of pharmaceutical support to manage the legitimate health conditions that come with age. That is reality, and medication is often genuinely life-extending. What this is about is specificity. Knowing that ibuprofen taken for pain relief at 10 p.m. behaves very differently in your cardiovascular system than ibuprofen taken at noon. Knowing that the sleep aid you have trusted for 3 years has been quietly adding anticholinergic burden to your brain every single night. Knowing that the timing of your blood pressure medication, not the medication itself, may be what is making you unsteady when you stand at 2 in the morning. Picture the next 12 months, mornings that feel sharper because the cotton is gone. Blood pressure readings that reflect what your cardiovascular system is actually doing rather than being distorted by nocturnal pharmaceutical suppression. Nights that are no longer a fall risk every time you need the bathroom. The independence too. Drive yourself to your appointments, carry your own groceries, remember your grandchildren without writing it down. That picture is not wishful thinking. It is what becomes possible when you have the specific, accurate information that allows you to make one precise change and let your biology do the rest. Take this information to your physician. Have the conversation. Your heart has been working for you every second of every night for your entire life. It deserves the same care in return.